Good day, my dear students. I am really happy to connect with you all to another interesting session on FMGE Recall 2025. I am Dr. Jamuna Shaktish, your faculty mentor, Pathology from Dopamine. So we'll start the session. First question that was asked is, for testing blood coagulation clotting parameters, blood is collected in which color-coded Vacutainer tube? A very practical question. As you're all aware that for blood clotting and coagulation parameters, that is for doing PT and APTT, we need to collect blood sample in blue colored Vacutainer. So we'll have a quick recap on the colors of Vacutainers that is used. So remember this. So the red color tube, it is used for serology where there is no anticoagulant, followed by the gray color tube where we have sodium fluoride as an anticoagulant used for sugar estimation. Then we have the EDTA tube for complete blood count, CBC and ESR and peripheral smear. We have the blue tube. So this is what is being asked, where we use it for coagulation studies, not only PT, APTT, but also fibrinogen, D-dimer, all the coagulation assays. We use the blue tube. Green heparin tube is used for bone marrow studies. The yellow tube is citrate for blood culture, followed by the pink tube. K2 EDTA will be the anticoagulant there, used basically for cross-matching. For blood grouping, we can use purple tube or the pink tube. So since this particular practical question is being asked, we also need to know what is the order of draw. How do we collect sample? So remember it with this mnemonic of your brother Robert gives lovely gifts. So whenever multiple samples are being asked for, so how do you collect? So the first thing, you need to collect it in the yellow Vacutainer. It goes with the color yellow also. So yellow Vacutainer for culture, followed by the blue one for PT, APTT, coagulation studies, followed by the red for serology, then green, followed by the purple, and the last will be sugar estimation in a gray color tube. So this is what we call as order of draw. This is how we need to collect when they are asking multiple samples. So the right response to this question is blue color tube. So we'll go to the next question. So here we have a 17 years old male presented with the complaints of delayed puberty, reduced facial hair with gynecomastia. On examination, he has a small, firm testis. He is very tall with the long limbs and a sparse body hair. His academics is also below average with mild learning difficulties. So what is the most common chromosomal pattern here? So as the scenario says, an adolescent male with a delayed puberty, it is a very clear-cut scenario of Klinefelter syndrome. So what is the chromosomal translocation for this Klinefelter syndrome? It is 47XXY. Okay, so for Klinefelter syndrome, you need to have 2 copies of X chromosome, 1 or more copies of Y chromosome. See, that's why we don't choose this option D. We choose option C. It is 47XXY, which is the classic Klinefelter syndrome. So something more about this Klinefelter syndrome. We are all aware that the person will be tall, slightly feminized physique will be there with the mild impaired IQ, tendency to lose the chest hair, and breast development in 30% of cases. So these people can have breast cancers. Because of hormonal imbalance, the persons can have osteoporosis, small, firm testis. So in Klinefelter syndrome, what are the possible more MCQs? What is the most common cause of hypogonadism in the male? Yes, it is Klinefelter syndrome. What is the most common genetic disease involving the sex chromosomes? It is again Klinefelter syndrome. And people with Klinefelter syndrome are having a high risk of extragonadal germ cell tumors compared to the normal people. They have a comparatively high risk. So what is the most common extragonadal germ cell tumor in people with Klinefelter syndrome? It is mediastinal teratomas. Mediastinal teratoma. Okay, remember it. Again, a potential source of MCQ. And these people also have multiple cardiac anomalies can be present, ranging from ASD, VSD. Even they have a high risk of mitral valve prolapse. So this can present again in adolescent age. So this is something about Klinefelter syndrome. A very basic question, which of the following is pro-apoptotic? So we know in apoptosis, which is programmed cell death, we have pro-apoptotic genes on one hand, we have anti-apoptotic genes on the other hand. So what are these pro-apoptotic genes? BCL2, BCLXL, MCL1. So all these 3 genes are anti-apoptotic. So what is pro-apoptotic here? It is BAX. So we have 2 pro-apoptotic gene. One is BAX other is back. So we'll quickly see about this apoptosis, also known as programmed cell death. Programmed cell death is apoptosis. So what are the pro-apoptotic genes, which is back. So what are the three anti-apoptotic genes so far we are aware, which is BCL2, which is a classic gene involved in follicular lymphoma, then BCLXL, then we have MCL1. So these are the anti-apoptotic genes. We also have genes which are called regulated apoptotic initiators, which will have only one VH domain. So what are they? Which is BAD, BIM, you have PUMA, NOXA. So these are all regulated apoptotic initiators. So one more thing is there are some mitochondrial proteins which will inhibit physiological inhibitors of apoptosis. So what happens? These mitochondrial proteins will combine with the inhibitors of apoptosis. Thereby, this will inactivate them. So which will cause apoptosis. So what are those mitochondrial proteins? We have so far two proteins which are there, which are SMAC and Diablo. Okay, so this is something about apoptosis. So the next question, a young boy presents with joint swelling after a fall. Laboratory investigation shows normal PT with the elevated APTT. What is the most likely diagnosis? So we'll see the choices here. So as you can see, choice C, iron deficiency anemia has nothing to do with this. So we'll exclude it. Very basic thing we will exclude. So we have three choices, and the child is having joint swelling. So it is heme arthrosis. Okay. So heme arthrosis, what type of bleeding is this thing? It is a deep bleeding. So it is not a superficial bleeding. So because it is not a superficial bleeding, we can rule out platelet function disorders as well. Similarly, because it is not a superficial bleeding, we will rule out von Willebrand's disease as well. Okay. So remember, both von Willebrand's disease and hemophilia. So both will have normal PT with elevated APTT. So how do you differentiate between the two? So if the bleeding is superficial, for example, like a skin bleeding or a mucous membrane bleeding, so something like that. If it is superficial, we are dealing with von Willebrand's disease. If it is a deeper bleeding, we are dealing with hemophilia. And how do we confirm whether it is von Willebrand's disease or hemophilia? By doing ristochetin assay. So ristochetin cofactor assay in von Willebrand's disease, and we do what is called as mixing studies. So to differentiate between von Willebrand's disease and hemophilia. Okay, so here the right response would be hemophilia. Again, it is a boy. So a boy with the normal PT, elevated APTT with hemarthrosis, probably it is hemophilia. So again, this diagram, we have so many MCQs in this particular diagram all the time. So I want all of you to be familiar with this diagram. We have discussed this diagram so many times. So remember, this von Willebrand's factor. Von Willebrand's factor has two roles in the endothelium. So what is the first role? As you can see here, whenever there is an endothelial dysfunction, so when the platelet plug to be formed, so what is between this platelet plug and the endothelium? So in the middle, what is the adhesive there in the middle? It is von Willebrand's factor. So von Willebrand's factor through this receptor. So see this receptor, it is GP1B9. So this particular receptor, from the platelet binds with the von Willebrand's factor. This von Willebrand's factor is binding with the endothelium. So that is one role of von Willebrand's factor. So what is the second role of von Willebrand's factor? As you can see here, factor 8. So factor 8, when it is binding with von Willebrand's factor, the half-life of factor 8 is prolonged. So without von Willebrand's factor, factor 8 will be very easily destroyed in the circulation. So if you want more factor 8 to stay for a longer time, you need von Willebrand's factor. So as a complex, they can survive for a long time. So when von Willebrand's factor is deficient, what happens? Factor 8 levels in the circulation also decreases. So the person can have a normal PT with the elevated APTT. Okay, so both von Willebrand's deficiency as well as factor 8 will have a normal PT with the elevated APTT. Again to say, PT is a function of extrinsic pathway, something to do with factor 7. Whereas APTT is a parameter of intrinsic pathway, isn't it? So, whenever APTT is prolonged, we need to know based on the nature of bleeding, we confirm whether it is hemophilia or von Willebrand's disease. So, again, all the time, be it any examination, there is always a question on pedigree analysis, which is consistently be there. So, please be familiar with the symbols and the pedigree analysis, which we have discussed so many times in our recap sessions as well. So, what is the status of this particular marked individual? So first, see the color, it is a pink color, so probably, and so this in the bracket indicates the person is adapted from another family. So this is the symbol for that. So we'll quickly recap all the pedigree symbols. So as you are aware, so male, female. So if there is a number in the middle, it is 3 male and 3 female. Whatever number is there, it is given. And what is this arrow indicates? It means a person is a proband. So proband male. Similarly, this is proband female. So what do you mean by proband? It means the first index case in the family from whom the genetic abnormalities was directed as proband. Okay. And as you are aware, when there is a cross over there, it means a person is deceased. So deceased male. Similarly, here it is deceased female. And whenever we have this box which is fully shaded, it means he is an affected person, isn't it? So this is affected male. So the one in the pink is affected female. So something with this dot is the male being examined. So the person who comes to our attention. So the male being examined. So here it is the female being examined. So something with the dot here, it means carrier. See, obviously, carrier will be a female, isn't it? So there is no symbol for the male like that. Okay. And whenever we have this upward arrow, it means we are dealing with twins. Okay. So they are male fraternal twins. It means 2 sperms and 2 ovum. The genetic makeup is different. So again, here, this is female fraternal twins. When you have this line like this, it means they are male identical twins. So here they are female identical twins. And when there is a box like this, it means they are adapted. So here it is male adapted. And here this symbol goes with female adapted. So whenever you understand this, you'll be able to answer any number of questions pertaining to pedigree analysis. So we'll move on to the next. So here we have a young patient presenting with multiple dark brown to black macules on the lips and buccal mucosa. Colonoscopy reveals multiple hematomatous polyps. What is the most likely diagnosis? A clear-cut, very straightforward case. We have discussed so many times. So what is the diagnosis here? It is a very classical Peutz-Jeghers syndrome. So people with the Peutz-Jeghers syndrome will have multiple dark brown to black macules, not only in the lips and buccal mucosa, also in the anal verge. Colonoscopy will have multiple hematomatous polyps. So what are the other choices? FAP, familial adenomatosis polyposis, mutation in the APC gene will cause FAP. And we have 2 syndromes, both are related to FAP, that is Gardner syndrome and Cronquist-Canada syndrome. So what is this Gardner syndrome? So they'll also have multiple polyps with osteomas, plus they'll have multiple epidermoid cysts. So that is Gardner syndrome. What about this Cronquist-Canada syndrome? So these people will also have multiple polyps with skin and nail lesions. So that is Cronquist-Canada syndrome. Cronquist-Canada syndrome is more related to autoimmune disorders also. Okay, so we'll see what is this Peutz-Jeghers syndrome. So what is the mode of inheritance in Peutz-Jeghers syndrome? It is autosomal dominant. What is the triad here? It means multiple hematomatous polyps plus this pigmented lesions in the oral mucosa and in the anal verge, plus family history. So that is the classic thing in Peutz-Jeghers syndrome. And what is the mutation? Mutation in SKT gene. And please look at the microscopy. So this has been again asked so many times. So whenever we have a Peutz-Jeghers syndrome, see, as you can see here, this is the polyp, the polypoidal. What is a polyp? It means a finger-like. So finger-like projection. And what is very important criteria for a Peutz-Jeghers syndrome is, see, this is a muscle. So when you have the muscle invaginating till the mucosa, so mucosa, that is submucosa invagination of smooth muscles. In an arborizing means in a finger-like pattern, it goes inside. So in an arborizing pattern. So this is very classical of this Peutz-Jeghers polyp. So this is also called as a Christmas tree appearance. So something like this, which is entering. So this is a polyp means. So the smooth muscles, which is going like this. So that is a very classic picture of Peutz-Jeghers syndrome, which can again be an important MCQ. So we'll go to the next. So which CD markers are typically positive in CLL, chronic lymphocytic leukemia? So again, we have discussed this particular question so many times. We have our favorite. See, what is this particular cell here? It is the smudge cell. So we have our favorite chart. I'm sure all of you have pasted in your study table. So this particular thing. So what is the marker? As we have already so many times we have told, if CD10 is positive, we have only one choice, that is follicular lymphoma. CD19 and 20 will be mostly positive in all the B cell tumors. Everything will be positive. So the specific marker, look here, for CLL, it is CD5 and CD23. So we'll go back to the option. So as the choice says, it is CD19, 20, 23 and CD5. 19 and 20 will be common for all. If CD10 is there for follicular lymphoma, so here the right answer for CLL is CD19, 20, 23 and CD5. So remember this particular chart. Again, a recap for hairy cell leukemia. Remember the CD11 along with the 3-digit number, it is 103. So hairy cell leukemia, remember the hair. So it is 11. Okay, so these are all the markers. If you remember it, definitely you will have one question pertaining to the CD markers. So the next question, a 2 years old, a small child presented with fever, lymphadenopathy. Hematoxylin eosin staining has the hallmark cells, and they have given the diagnosis straightforward, anaplastic large cell lymphoma. What is the most likely translocation? So the question is, what is the translocation for anaplastic large cell lymphoma? Very straightforward. Again, we have discussed it so many times. It is T25 is anaplastic large cell lymphoma again. So what is this 814? It is again Burkitt lymphoma. So this 1418 is our favorite follicular lymphoma. And we'll always recall this thing, which is 1114, which is mantle cell lymphoma. 25 is anaplastic large cell lymphoma. Something to do with 822, we have 922 translocation, which all of you are aware, which is actually Philadelphia seen in CML and some types of ALL. This 822, a number less than this, so 822 translocation is seen in a Burkitt lymphoma resistant type. The prognosis is poor. The poor prognosis of Burkitt lymphoma will have this translocation, where the tumor cells will have T cell morphology. So that is this 822 translocation. So here it is a case of anaplastic large cell lymphoma. So since it is given, what is this hallmark cell seen in anaplastic large cell lymphoma? So this is the hallmark cell. Remember this picture. See, can you see? It is something like a baby lying down, isn't it? So a horseshoe or an embryo cell. So this is exactly looking like an embryo. So this horseshoe or embryo cell. So which is a very classic picture of anaplastic large cell lymphoma. And all these tumors will have ALK positivity. So what is the immunohistochemistry marker? It is ALK positivity. Okay, so that is the classic picture of anaplastic large cell lymphoma. Next question, a young boy presented with history of ingestion of paint chips, leaves and soil Blood examination is conducted based on the history, suspected environmental exposure, what is the most likely agent. And the arrowhead points to something like this. So something in the RBC, where the periphery of the RBC, you can see blue to purple dots. So what is this blue to purple dot? So this is called basophilic stippling. Okay, so what is this basophilic stippling? What is the diagnosis in this scenario? It is a very classic case of lead poisoning, isn't it? The history says ingestion of paint chips, which will be high in lead, and the child is also having a basophilic stippling. Thalassemia major, any thalassemia also you can have a basophilic stippling, but here the history is not for thalassemia, so that we are ruling out. Iron deficiency anemia is also not possible because based on the history, it is also not possible. So the classic basophilic stippling seen in lead poisoning. So what are the causes of basophilic stippling? We'll remember it with the mnemonic of baso PH, P. So the P for PB, that is lead poisoning. So what is this B? Remember this beta thalassemia. Beta thalassemia. Okay, not only beta plus any thalassemia, even an alpha thalassemia will have. So just remember with the mnemonic like this. What is A? Anemia of chronic disease. All the anemia of chronic diseases can have basophilic stippling. Yes for sideroblastic anemia, where iron cannot be taken up by the RBC precursors, that is sideroblastic anemia. And what is other? O for other dyserythropoietic anemias. Dyserythropoietic anemias. So dyserythropoietic anemias can be because of congenital dyserythropoietic anemia, or even B12 deficiency, you can have dyserythropoiesis. So all these things are the causes of basophilic stippling. So not only lead, aluminium, so any heavy metal poisoning can cause basophilic stippling. So what is this basophilic stippling? So they are the remnants of ribosomal RNA. So that is basophilic stippling. Here with the scenario, we come to a diagnosis of lead poisoning. Next question. In Barrett's esophagus, we have discussed this so many times. What is the epithelial transformation? So what is the other name for Barrett's esophagus? It is also called CLO. So columnar lined esophagus. So it is the squamous epithelium which is getting converted into the columnar epithelium. See, as we have discussed so many times, so CA cervix, it is columnar getting converted to squamous. In the endocervix, to be specific. Okay, so that is metaplasia. In the esophagus, the reverse, that is the squamous converted into a columnar. So that is Barrett's esophagus. Okay. So this is a picture. So this is the squamous epithelial lining. This is the columnar epithelial lining. So when the squamous is getting converted into columnar, we call that as Barrett's esophagus. So what is the problem in Barrett's esophagus? People with the Barrett's esophagus have an increased risk of adenocarcinoma. Okay. We'll go to the next question. Next question. So Bernard-Soulier syndrome is caused by the defect in which of the following platelet glycoproteins? So as we have already discussed, you see this familiar picture which we have just discussed. So there are two receptors in the platelets. One is a GP1B9 and the second is a GP2B3A. So this GP1B/9, so it is GP1B/9. So this mutation will cause Bernard-Soulier syndrome. Whereas mutation in this particular receptor will cause Glanzmann's thrombocythemia. So these two are the platelet functional disorders. So here, Bernard-Soulier syndrome is caused by the defect in which of the following glycoproteins? It is GP1B9. So this is the right response. 2B3A, this will cause Glanzmann's thrombocythemia. Next question, a patient with the renal disease undergoes biopsy. So they have clearly given congruent staining. The deposit shows a apple green birefringence under polarized light. A very straightforward question. So what is the most likely diagnosis? It is a clear-cut case of amyloidosis. So what are the stains used in amyloid? You know that amyloid means what is this thing? It is actually a extracellular protein deposition. So that is amyloidosis, and the amyloidosis, the causes can be either primary or secondary. Depending on the organ involved, it can be systemic or localized amyloidosis. And what are the special stains we use in amyloidosis? Remember, Lugol's iodine. So Lugol's iodine is used to detect amyloid in the gross specimens. So whenever we receive the specimen, if we paint Lugol's iodine, if that takes a yellow color, probably we are dealing with amyloid. You can have a clinical suspicion. What are all the microscopic stains? The specific stain is Congo red. You can also use thioflavin S, thioflavin T. Similarly, PAS and Alcian blue can also be used to detect, but the specific stain is Congo red. So that is the specific stain. And if you want to see the apple green birefringence, you have to do a Congo red stain. That particular slide you need to see under polarizing microscopy to see the apple green birefringence. So the next question, a 25 years old man presents with headache, visual disturbance, hypertension. MRI shows a typical finding of cerebellar hemangioblastoma. Abdominal imaging shows multiple cysts in the kidney with a solid renal mass suggesting renal cell carcinoma. So there is also a family history. His father died of similar findings and died from a brain tumor. So what is the chromosomal abnormality? So what is the familial syndrome associated with renal cell carcinoma? It is von Hippel-Lindau syndrome, isn't it? So von Hippel-Lindau syndrome. So here the question is not straightforward. So they are asking what is the mutation in von Hippel-Lindau syndrome. So what is the mutation? It is deletion on chromosome 3p. So the right response is deletion of chromosome 3p in von Hippel-Lindau syndrome. So these people, what are all the components? The scenario says very clearly they will have cerebellar hemangioblastoma. They can also have pheochromocytoma, renal cell carcinoma RCC. They can have cyst in the pancreas, pancreatic cyst, renal cyst. So all these are possible. Von Hippel-Lindau, it is actually, what is this von Hippel-Lindau gene? So this is actually a tumor suppressor gene. Both the copies of the gene to be mutated. So that's why there is a family history. So one copy is already mutated. Once the second copy is also mutated, according to the Knudsen's hypothesis, the person will have cerebellar hemangioblastoma, pheochromocytoma, and all the other clinical features. So deletion of chromosome 3p. Next question. A newborn presenting with the upward slanting palpebral fissure, the classic Chinese eye appearance with the flat facial profile and hypotonia. The karyotyping shows this particular thing, 5p deletion. So there is only one diagnosis to this. What is this 5p deletion? It is Cry-du-Chat syndrome. Okay, so what is the meaning of the word chat? So chat is basically a French word. Okay, so chat means cat. So cry means the sound, isn't it? So call like a cat. So whenever the child is crying, the child will cry like a cat, as though a cat is producing some sound. So that is a classic sound which we hear in this Cry-du-Chat syndrome because of deletion of 5p. So that's why the terminology, call of a cat, that is Cry-du-Chat syndrome. So what are all the features of this Cry-du-Chat syndrome? So the child will have, most of the genetic disorders, the features will be the same. Here, the most specific, remember, is that Cry-du-Chat. In addition, the child will have a large head compared to the face. See, the upper portion will be very large and a tall forehead will be there. Hypertelorism will be there. Downward slant of the palpebral fissures with prominent epicanthal folds. All the findings will be there. But this typical cry is a classic thing seen in Cry-du-Chat syndrome because of deletion of 5p. So next question. HNPCC, hereditary non-polyposis colorectal cancer, is caused by the mutation of what gene? So in colorectal cancer, we have two things. One is the FAP, familial adenomatosis polyposis colon. Second is the hereditary non-polyposis colorectal cancer, HNPCC. So the first one, APC, is because of familial adenomatous polyposis. So MYC gene is a very common gene seen in many cancers. So this is something related with the telomeres. So which is not related to this particular scenario. MYC is also not there. It is mismatch repair gene, MMR. Mismatch repair genes will be caused by the will be causing HNPCC, which is hereditary non-polyposis colorectal cancer. So what is the other term or the closely related term for HNPCC is Lynch syndrome. So because of mutation in the mismatch repair gene. And what is the clinical criteria called? It is called Amsterdam criteria. So that is the criteria. And how do you confirm the diagnosis of HNPCC? Using immunohistochemistry markers, histopathology, HPE plus IHC will give a diagnosis of hereditary non-polyposis colorectal cancer syndrome. You have to detect the mutation here. The mismatch repair mutations, that is MSH mutations, will be detected. Okay, so this is the biopsy part. Here in the MSH mutation, genetic analysis will reveal HNPCC or the Lynch syndrome. So we'll go to the next question. 25 years old women presents with the lower abdominal discomfort. This is the surgical specimen which is given. What is the most likely diagnosis? As you can beautifully see here. So what and all you see here? So this is the hair. Here you can see the tooth, well-formed tooth. Here you can see the some pultaceous material with the, again, well-formed structure is there. Some glial matrix is there. So it is actually a teratoma. And a mature teratoma will be solitary cystic. So this is actually an immature teratoma. Very straightforward question. Serous cyst adenoma. Serous tumors will be usually bilateral. Endometrioma is a distractor. It has nothing to do with any tumors. It is the terminology itself is a misnomer. So the next question, very, very important question. FBN1 gene mutation is seen in which following genetic disorder? So many times we have discussed FBN1 gene is a classic gene seen in Marfan syndrome. So something to do with Marfan syndrome. What is the mode of inheritance of Marfan syndrome? It is autosomal dominant. What is the gene involved? It is FBN1 gene. So what are the organs involved? So people with the Marfan syndrome will be very tall and their skin will be highly elastic, isn't it? So what are the organs involved? Skin will be involved. What is the classic sign? Any person with the bilateral ectopia lentis. So what happens? Both the lens, there will be lens dislocation because of the weakening of the ciliary zonule, so that both the lens will get dislocated. So bilateral ectopia lentis is there. We should always suspect a diagnosis of Marfan syndrome. So organs involved, one is skin, second is the eye. What is the life-threatening complication which we are afraid in a patient with Marfan syndrome? That is aortic incompetence will be there. So the person can go in for a severe massive aortic dissection. So organs involved, eye, skin and CVS. Okay, these are the organs involved. So what is the dreaded complication? It is aortic dissection. What is the classic sign? Bilateral ectopia lentis is the classic sign. What is the diagnostic criteria for Marfan syndrome? Similar to the Amsterdam criteria for HNPCC. Here, what is the diagnostic criteria? It is the Ghent criteria. So used on the Ghent clinical criteria, we make a diagnosis of clinical diagnosis of Marfan syndrome. Then you have to look for the classic FBN1 gene to confirm the diagnosis. So next question, very, very straightforward. A newborn presented with a single palmar crease. Whenever there is a single palmar crease, there won't be any other thing, only one line will be there. So what is the finding? A classic case of Down syndrome, which is 21 trisomy. So what about the other? Edwards syndrome is 18 trisomy. So what is this Patau syndrome, which is 13 trisomy? So what is this Turner syndrome, which is 45 XO? And you know Klinefelter syndrome? which is 47XXY. Okay, so here it is a very classic case of Down syndrome. So Down syndrome, you're all aware, low set tears, abundant nuchal thickness, single palmar crease, intestinal stenosis, gap between the first and second toe, which is called as the saddle gap. So as they wear the sandal, the gap between the first and second toe is there, which is saddle gap. So look here, predisposition to leukemia. What leukemia? It is AML M7, acute myeloid leukemia M7. What is this M7? It is acute megakaryocytic leukemia. So that is AML M7. They'll also have umbilical hernia, cardiac defects will be there, many cardiac anomalies like ASD, VSD, everything can be there. So remember this AML M7 in people with Down syndrome. That is a separate category is also there in the AML classification. That is AML with the Down syndrome. That is a separate category. Then a chronic smoker who is working in a cement factory for 20 years develop mesothelioma. So the clue is cement factory, mesothelioma. So very straightforward. What is the diagnosis? It is asbestosis. So people working in the asbestos industry have a definite risk of mesothelioma. So in mesothelioma, so what is the carcinogen which will definitely cause mesothelioma? It is asbestos. Okay, so what is silicosis? Silica dust. What is this bagasosis? It is sugar cane. Okay, so asbestosis will cause mesothelioma. And even if this image is given, so what are these bodies in asbestosis? They are called ferruginous bodies, which are nothing but asbestos, which will be engulfed by the macrophages. And these macrophages will have a iron coating. So they are called ferruginous bodies. So they'll be typically dumbbell-shaped bodies. Dumbbell-shaped bodies. Beaded, dumbbell beaded bodies. So it will be like this. As you can see the picture here, it will be like this. So this is the classic ferruginous body seen in asbestosis. Another question in pneumoconiasis itself. Chest X-ray of a 40-year-old male with the history of occupational dust exposure showing bilateral hilar lymphadenopathy with the thin rim. So the key word here is the eggshell calcification. Very simple. Whenever there is an eggshell calcification, there is only one diagnosis. What it is? It is silica dust silicosis. Okay. See again, sarcoidosis. Patients with sarcoidosis will also have a bilateral hilar lymphadenopathy, but occupational exposure is one clue. Eggshell calcification is another clue, which points to the diagnosis of silicosis. So what is this silicosis? It is the inhalation of silica dust. And see, as you can see, the arrowhead points to the eggshell calcification. And what will be the histopathology image? As you can see here, you whorls of collagen. See, whatever you see in pink, so this is collagen. Surrounded by, so this is the whorls of collagen surrounded by, so what is here? Surrounded by inflammatory cells plus macrophages plus carbon particles. So this is the classic picture of silicosis. This is the histopathology image of silicosis. We'll go to the next one. So very basic, again an application-based question. In pap smear cytology, what is the most appropriate fixative used to preserve the cellular details immediately after smearing? So what is the fixative we use for pap smear? So for pap smear, we need to use alcohol-based fixative. 10% neutral buffered formalin for tissues, isn't it? For histopathology. Histopathology, we use 10% buffered formalin. We use 50% formaldehyde. There is no 50% formaldehyde which is available. The maximum will be 40% only. So no such formaldehyde is available. We'll rule out that. So among the two choices, what fixative we use is 95% ethanol. So if at all not 95% ethanol, we can also use isopropyl alcohol. Either 95% ethanol or isopropyl alcohol will be the fixative used for PAPS. Next question. Mutation in SOD1 gene is most commonly associated with which of the following condition? So again, a straightforward question similar to the FBN1 gene in morphans. SOD1 gene is typically seen in amyotrophic lateral sclerosis. So what is the other terminology for amyotrophic lateral sclerosis? It is a low Gehrig's disease because of mutation of SOD1 gene. What is this SOD1? It is superoxide dismutase 1 gene. And who is the celebrity, the famous celebrity who had this amyotrophic lateral sclerosis? None other than Stephen Hawking. So what happened? It is a debilitating disorder because of degeneration of the voluntary motor neurons. So all the voluntary muscles will be affected slowly. So all the voluntary movements like walking, using the hands, eating, everything will be affected gradually. And what would be the cause of death? Because of the failure of the supporting musculature of the lung. So pulmonary failure would be the cause of death in people with amyotrophic lateral sclerosis. Pulmonary failure will cause death in amyotrophic lateral sclerosis. And actually, Stephen Hawking's, usually the lifespan for people with amyotrophic lateral sclerosis is probably 5 years. So Stephen Hawking is one person who has a record in that as well. So he lived for 38 years actually. 38 years with amyotrophic lateral sclerosis. Okay. It doesn't affect the intellect. It only affects the degeneration of the voluntary muscle of the body because of degeneration of the voluntary motor neurons. Blood transfusion reaction is mediated by what type of hypersensitivity? We are all aware there are 4 types of hypersensitivity. So type 1 is immediate hypersensitivity. Type 2 is antibody mediated. Type 3 is immune complex mediated. Type 4 is delayed hypersensitivity. And transfusion reaction is typically a type 2 hypersensitivity. Our familiar chart again. Immediate hypersensitivity is anaphylaxis, allergy, bronchial asthma, and atopy. Antibody mediated, that is type 2 hypersensitivity, where the antibody in the circulation will go and bind with the RBCs. So transfusion reactions, autoimmune hemolytic anemia, Goodpascher's, myasthenia gravis, pernicious anemia, pemphigus vulgaris, and all the transfusion reactions. Because of incompatibility, all those things will cause type 2 hypersensitivity. So what is type 3? It is immune complex deposition seen in SLE, post-streptococcal glomerulonephritis, polyarteritis nodosa, serum sickness and Orthus reaction. Type 4 is delayed hypersensitivity. The classic example is TB. In addition, I again want you to remember contact dermatitis and insulin-dependent diabetes mellitus, multiple sclerosis. So here the right response is antibody mediated, that is type 2 hypersensitivity. So the last question, which of the following best describe the oral lesion seen in Kaposi sarcoma? So Kaposi sarcoma, white flat patches, they are not flat, they will be elevated, so it is ruled out. Ulcerative painful lesion, they are not that painful, so that is ruled out. Red, smooth, non-elevated, no, they are all elevated macules, so it is ruled out. The classic will be purple red elevated lesion, which is a classic lesion seen in Kaposi sarcoma. So about Kaposi sarcoma, what is the etiology of Kaposi sarcoma? It is Kaposi sarcoma virus, also known as HHV, human herpes virus type 8. So that is the etiology of Kaposi sarcoma. What are the types? There are 4 types of Kaposi sarcoma. What are they? We have sporadic, so which is spontaneous. We have endemic. Endemic seen mainly in Africa. We have epidemic type. Epidemic type seen in people with HIV. Followed by the 4th type, which is iatrogenic, seen in people with transplant, especially transplant patients. So these are all the 4 types of Kaposi sarcoma. And what are the lesions and what are the stages? So there are basically 3 stages, which is actually the patch stage, followed by the plaque, followed by the tumor. So lesion, what are the lesion? For the patch, it is the macules will be there. And for the plaque, the person will have papules. And for the tumor, the person will have nodules. So these are all the 3 lesions which are macule, papule, and nodule. The 3 stages will be patch stage, plaque stage, and the tumor stage. So that is about Kaposi sarcoma. So with that, we'll finish. Thank you so much.